look at this. Look at this group of presenters we have brought to you today. Now, I do want to say before we get started that language can be a very personal thing. So I'm going to ask you please to just sit back and relax and join in with us as we go through this presentation. If some of this language brings about discomfort, I'm going to suggest that you lean into that and that you share those comments in the chat. If some of it resonates for you, please give us a shout out and let's talk about that. We realize that different groups have slightly different nuances for language. What you will be learning today is the nuance from each of these four presenters and from their perspective. Now, this is a safe space, so you can share any thoughts that you would like to share. Please know that even though these presenters may use a different lens than is the one that you might use, all are focused on equity. Let's move to the next slide. So we're going to be talking about person-centered language. And we just want to do a refresher here, make sure we're all on the same page. I'm not going to read to you. We know that person-centered language is the language we use to convey respect and acceptance across all groups. It involves using language that puts the person before their diagnosis, disability, or other characteristics. However, we do know that some people choose to self-identify with a different language. And here's the example. A person in recovery from substance use may refer to themselves as an addict or an alcoholic. That is their perspective, but that does not imply permission for others to use that terminology. Next slide, please. So here are just a few examples of moving from diagnostic language to more person-centered language. I know that our audience has seen these before, and these are just 4 examples. You're going to hear many, many more today. Next slide, please. And taking a person-centered approach. It sometimes takes a minute to really let this get absorbed into your soul. But what we are trying to do is make that strong effort to celebrate what makes people unique and to learn what's important to them and to support all of our community members to be engaged and building meaningful relationships within their communities. So with that, I'm going to ask you please to sit back and relax, get ready for an amazing opportunity here with these 4 incredible speakers. And please, please put your comments in the chat. We will do our best to do a Q&A at the end, and we love hearing from you. And with that, I'll turn this over to Seth.
Thank you very much. Can you hear me all right?
Yes. Okay,
good. It's very good to be here. I'm very honored to be here, and I hope that my story will make a difference. We can go to the next slide, please. So I'm going to be talking about the grand challenge to eliminate the stigma around mental health and substance use disorders. That I'm leading that initiative, but I'm not a mental health service provider, and I want to share about my own personal story before I get into the details of it. So my expertise is actually in other areas. I worked at the World Bank for 13 years, where I had a chance to see really large projects take place all around the world, those that succeeded and those that didn't. And then I've been self-employed as a consultant, working on strategy and innovation for the last 20 plus years. I've worked with over 100 CEOs of nonprofits during that time. And about 4 years ago, I was asked by the Huntsman Mental Health Institute to help them think about how they could eliminate stigma on a national scale. Go ahead to the next slide, please. What I'd like to share when I was making that decision is a little bit about my personal life. Since I'm not a mental health expert, I don't have experience providing mental health services. This is a picture of me with my mother. And that picture was taken probably in 1960 when I was less than a year old. I was born in 1959. And this is my, in the bottom in the middle, this is my mother and I when I was about 10 years old in Austin, Texas, where we lived at the time. Um, in that lower picture, this picture was taken about the time that my mother began to exhibit symptoms of schizophrenia. She developed schizophrenia, and it was very intense. It was extremely scary for me because I relied on her to let me know what was real, what I needed to be concerned about, and to guide me through life in all different ways. And I first began to get an inkling that something was wrong with her when she would drive me around in the car, and she started telling me about the red car that was following us. And after many times of not being able to find the red car, I remember one day in particular when I was horrified to realize there was no red car and that something was wrong with my mother. My father discovered that something was wrong with his wife when he found that all of our savings had been depleted because my mother was buying groceries and then throwing them out. She believed that people were pumping poisonous gas into our groceries. And so she was throwing them out almost immediately after having bought them. And she completely emptied my parents' savings account in the process. This began a really tough period of life for all of us. And she did not get good help. It was a long time before we even knew what was going on. She had severe hallucinations, auditory hallucinations, as well as visual. She was paranoid. She also had a PhD in special education. And so while all of this was happening, she knew that it was happening to her, and she would talk about that. This went on for probably about 25 years. There were multiple suicide attempts. She was institutionalized at least once against her will. It was really horrific for myself. And my family fell apart. I moved out of the house when I was 16, and I didn't start rebuilding my relationship with my mother until the 90s. And you can see in the upper right hand there, that's me and my mom when she finally got on good meds. That she fortunately had another 8 to 10 years of her life where we had a really strong and powerful relationship where we were able to be honest with each other. And she was always able to talk about her condition. But the stigma really lodged itself in my mind around my mother. When I was a youngster in elementary school, I did not tell anyone what was going on in our home. I was scared to. I didn't want my friends to come over to my house. Our house was sometimes a war zone. We had broken things all over the place. My mother regularly destroyed television sets because she was sure that people were watching us through them. And I was embarrassed, deeply embarrassed by what was going on in my home. And nobody ever took the time to explain it to me. Not all of the psychiatrists that we visited, the mental health care workers that we interfaced with, the people who were in charge of her therapy, none of them ever spent time with me to talk about what it was like to be the child and how I could take care of myself. And as a result of that, I was just highly stigmatized. I was afraid to talk about it. And I realized when I was, when my mother got good medication and she came back, I realized that this was a problem for me because the stigma that I carried around my mother was preventing me from loving her at the way that I wanted to as a full human being. And so I sought out therapy myself as a young adult to try and understand how I could accept her for who she was. When I began the work with the Grand Challenge to eliminate stigma, one of the first things I discovered was the use of language and the impact it was having on the way I thought about my mother and our family. I often called my mother a schizophrenic, or I would talk about her having a screw loose, or being crazy. I didn't realize that these were problems in how, and they had direct impact on so many of my thoughts, not just the thoughts where I would use those words, but that the impact would bleed over into other thoughts. And so I had to start changing the way I thought about her and what she went through. And I developed a tremendous amount of compassion for her and gratitude that she was able to hang on and struggle for so long without very much help at all. and that we were able to have almost a decade at the end of her life where we had a real and caring relationship. Please go to the next slide. And you can just go ahead and build this slide. The grand challenge to eliminate stigma is based on the 2016 the National Academy's report, Ending Discrimination Against People with Mental and Substance Use Disorders. And that's a link to it in the slide that you'll get when we're done. The Academy report is free, and you can download it over the web of stigma, which I'm going to go over in just a moment. But it also says that it's going to take at least 10 to 20 years to turn the country around. And that's something that we have committed to at Stop Stigma Together. And if you want to know more about this initiative, you can go to stopstigmatogether.org. We are building partnerships, and I'm going to talk about that all across the country. Our goal is for all 350 million American citizens to think of mental health as health and to remove stigma as a barrier to getting treatment. We know that mental health is complicated, it's multidimensional, it's systemic. We also know that it kills, that people do not get treatment for substance use disorders and serious mental illness because they are afraid of how it will make them look or how they will think of themselves even. And yet, we also know that stigma is a social construct, which means that it is changeable. Go to the next slide, please. I want to talk about the three dimensions of stigma. The first two are on this slide. The first is structural. Structural stigma is stigma that's embedded in laws and policies. It's literally embedded in legislation. Or when we talk about policies, we're talking about workplace policy, house of worship policy, scout policy, any place where there are rules for how people have to behave when they are together. If stigma is embedded in policy, that means that you can be compliant, i.e. doing the right thing, and still perpetuating or amplifying stigma. And this is why it's so important for us to identify it and then amend it. The Stop Stigma Together has a policy action network that includes such organizations as the Kennedy Forum, the National Council for Mental Wellbeing, Inseparable, the American Psychiatric Association, and others who are working together to identify laws across the nation, as well as policy in the workplace and other locations, and make the necessary changes so that we live in a stigma-free environment. Social stigma is how people behave when they're in groups, when they're sitting together in the living room, when they're gathering at the shopping mall, when they're in a bar or a coffee shop, anywhere people gather, workplace. It's how we interact and the sentences we use. And if you could go on to the next slide, we also know that stigma is individual and that it manifests in the internal dialogue. And that's the type of stigma I was sharing about earlier, about how my own mind was actually biasing me with prejudice against my mother. And that I had to learn to really do the inner work so that I could see her as a whole human being who was experiencing schizophrenia. The grand challenge targets all three of these areas and works on them together and separately. Please go to the next slide. So I want to share a video with you that one of our partners is the Ad Council. You probably know the Ad Council because they developed Smokey the Bear. They actually developed Rosie the Riveter way back when. And they developed the phrase, friends don't let friends drive drunk. They take on national campaigns to help America where they believe America needs assistance. And after the pandemic concluded, they did independent research and they discovered that mental health was the next major challenge facing America. And so I'd like you to see the first of the PSAs that they're rolling out across the nation. Please go ahead and play that now.
I wonder if you know that I want the best for you. I know you're going through a lot. I wonder if you know that the big homie needs help too. He can't just rebound from everything. I know you've been grinding.
Let's go, let's go, let's go.
But how long will you fight solo? I wonder if you know that we can get help. I wonder why we waited so long. I'm not wondering anymore. Love, your mind. Let's see how far we can go.
And you can go to loveyourmindtoday.org and see all of the PSAs that the Ad Council is putting together. They're getting hit millions of times. This video is working very well. And I will tell you, you could probably guess when you watch that, this video was designed to target two groups of people demographically who are generally resistant to getting mental health care, and that is young Black
Elmo's daddy taught him that when he has a big feeling like being frustrated, humming a song can help you feel better. We all have big feelings, and we are all here for one another. Love your mind.
Thank you. You can go to the next slide. You'll be seeing PSAs with the theme Love Your Mind rolling out across the country, targeting many different demographics. The next thing that I would like to talk about is a little bit about how our structure works. The Huntsman Mental Health Institute in Salt Lake City, Utah is our backbone organization. We have an executive committee that looks at all of our strategy and a national leadership steering team. Go to the next slide. That is made up of the leaders of many, many different organizations. And go on to the next slide. These are the folks, executives from these organizations who are guiding our leadership steering team. We're also reaching out across the country through a variety of methods. If you would go to the next slide. One of those is that we have communities of practice forming. Those communities of practice that are currently up and running include workplace, rural America, and rural America is such, it's an umbrella term which really does not suffice because every community in rural America is different. So we have many, many different communities that are not in urban settings that are covered by this. Journalism in the news. We know it's important that reporters cover mental health and substance use disorders in ways that do not promote stigma. Entertainment and media. We're working with many organizations. In fact, at our upcoming summit, which I will tell you about, we will probably have producers and talent from shows like Ted Lasso or Shrinking. And then children, youth, and family. And obviously, we have Sesame Workshop working with us and policy. If you go to the next slide. This is our summit that's coming up. And for more information, you can scan this QR code right here. And even if you're not interested in coming to the summit, I would suggest that you scan the QR code and take a look at the program so that you can see the wide and varied partners who are participating in helping us to eliminate stigma. Today, we have over 300 organizations that are working together with us. There's no barrier to entry. There's no financial commitment required. If you're interested in being a partner, you can contact me directly or you can go to the website. If you go to the next slide and then the next one after that. These are just more information about the upcoming summit. We'd love to have you, and I'd be happy to answer any questions. With that, let me turn it over to Raquel.
Hi, everyone. I am Raquel Rosa. I am the Community Relations Specialist at the National Disability Rights Network. In that role, I provide technical assistance to all 57 protection and advocacy agencies throughout the country and territories. I focus on providing training and technical assistance for intake, information and referrals, outreach, and their PAMI advisory councils. PAMI is Protection and Advocacy for Individuals with Mental Illness. So I am here to talk a little bit about how we are, as community members with the mental health community, how we are bolstering one another and informing other people of person-centered language, person-centered approaches, and to kind of piggyback off of what Seth was talking about, destigmatizing and supporting one another, holding one another accountable for a safe environment and a safe space for people to identify and share, and hopefully to uplift our community and make sure that those around us see us as people and not as diagnoses. So if I can go to the next slide. So I just have a few strategies here. Again, this is really more about community and peer-facing activities and approaches. One of the ways that in my career, which by the way, like Seth, my focus has not been on mental health exclusively. I am somebody with lived experience, but professionally, I have focused on adults with intellectual and developmental disabilities. So kind of piggybacking off of the self-advocacy movement, I really try to infuse that approach and those strategies in this work here. We know that grassroots work is super important, and legislative activities are some of the ways that we can do that. So when we're meeting with policymakers, people who we vote for, people who are running for office, it's really important to and for us to talk about the topics that are important to and for who we are, and that we are using language that is specific to us. I'm a person with lived experience. I'm a person with X diagnosis. This has been my experience with this. Moving away from the diagnostic and medical model. I think in our world, we really focus on those labels, and we're really separating the human from all of it. So the way how we write our stories, the way we craft our elevator pitches, the way we share our stories with people who are making really big decisions on our behalf, it's super duper important that we are directly and indirectly reminding them that shifting the language and shifting the lens focuses on the human. I would also say that part of this also includes the development of peer mentorship relationships. I think, and again, piggybacking off of self-advocacy, I think one of the ways that we grow stronger in our work is by recognizing one another in our leadership styles and leadership skills. And sometimes, you know, our mentors choose us and sometimes we choose them, and kind of leaning into the style and the language and the tips that we offer one another to strengthen our advocacy for ourselves, for our friends, for our communities. Next slide, please. Super important overall, but also to me, I am a Latina, and we know that people with intersectionalized identities tend to be the most marginalized. I'm not saying that that is necessarily my experience. I just know that in the global picture, that has been a major part. In my observation, people who are the most under-recognized are often assumed not great people, scary, unsafe, unwieldy. And unfortunately, this includes being excluded from the really, really critical work that we advance in our world. Sometimes it's intentional and sometimes it's unintentional. And that's why I have the UN framed in parentheses. I think there are folks in our larger advocacy world who unintentionally speak for the community. And I understand where that comes from, right? We want to make sure that we have strategic points of information and asks. And unfortunately, sometimes there are folks who I think believe I know better. So it's okay for me to speak on behalf of this community. And then sometimes, unfortunately, it is intentional. I have heard people say things like, we cannot have somebody who's been institutionalized speak. What we believe they're going to say or how they're going to respond might really cause a lot of problems. Without coaching folks, without assuming the skills and the ability to share that story naturally, and with emphasis on certain details. So it's really important for us within this work to make sure that we are intentionally identifying the folks who are the most likely to be isolated from this work. That includes people who are formerly incarcerated, currently and formerly incarcerated, people who have been institutionalized in psychiatric facilities, people of color, people with varying socioeconomic statuses, especially people who come from lower income situations. And finally, people who don't speak English as a first language and other cultural barriers. And I have barriers in quotation marks because it's not that I am recognizing barriers for what they are, but I'm also trying to frame it as something that we envision as a barrier, but not really is a barrier. It could be a number of things, right? It could be just unrelatability. I don't know what that person's experience is, so we don't see things in the same way because we don't come from the same place. That person is generationally different. That person loves somebody differently than I love. Those kinds of barriers are really there through the eye of the beholder, I guess, and it really does have an effect on the work that we have. So I really encourage us as a community to lean into the folks who we may not know and who might be a little bit, I don't know, trepidatious to begin that conversation. But I really encourage all of us to do the work to include people meaningfully and intentionally and authentically in joining this. It's very critical. If we want to end the stigma, if we want to save people's lives, if we want people to feel safe and heard and seen, it is so important that we are inclusive of people of all communities. Next slide, please. Another strategy that I'm going to recommend is how we build coalitions. Recently, I met with a PAMI advisory council, and one of the questions a council member asked was, how do we get in touch with each other? She says, I feel very isolated where I'm at. I have the people in my immediate community, but I don't know who else to connect with. And this work is bigger than mental health. It's about socioeconomics. It's about race. It's about sexuality and gender identity. It's so many things. It's parenthood versus non-parenthood. So here are just a few ideas. Natural places where people are, going to school events and other meetings that involve families, people who care for young people, support groups, collaborating with other local grassroots and allies. That could be, again, beyond mental health. It could be something like your local human rights campaign chapter. It could be another disability group that may not focus on mental health, but may focus on other diagnoses, and that overall experience of not necessarily being heard and seen, and having really important decisions made on behalf, and educating people to pump up the good stuff and get rid of the old stuff, the old ways, the old language. And then finally, cross-pollinating with other advocacy and activist groups. And the reason why I say this, there's the collaboration with the grassroots, but then I'm also talking about here the well-organized, already existing groups. We know that throughout time, there have been many of a movement, and sometimes they ebb and flow. But from my vantage point, the disability rights movement has been full steam ahead for decades. And so I know we've got allies who cross the gamut of diagnosis and experience and intentional movement. And so I really encourage all of us to connect with who are those other folks within our space and beyond. And I think that's my last slide. Can we check? Yes. So if you have any questions, my contact information is here. Actually, the website's here. I can put my contact information in the chat, and I am going to pass it over to Zipporah.
All right. Thank you so much, Raquel. And thank you everybody who is joining us today. I am very excited to be able to be a part of this webinar and to actually present with the other panelists, because this is a topic that is very near and dear to me. Can we move to the next slide? So it is important to me for a couple of reasons. So as an introduction, I am Dr. Zipporah Levi-Shackleford. A lot of people call me Dr. Z. And I am the founder of Creative Approach Development Center, which is an organization in Richmond, Virginia, where we work with individuals with dual diagnoses. So that's individuals with disabilities, mainly intellectual developmental disabilities, as well as a mental health diagnosis. We work with those individuals and teach them how to identify their personal goals and strengths, and then use those skills to advocate for other supports and access to resources to help them improve their quality of life. The reason why I got into this field is because it is something that has surrounded me my entire life. I have a younger brother who is diagnosed with a mental illness, and I myself have a diagnosis of severe anxiety and depression. And I'm also a parent. I have 4 children, and 2 of my children also have the severe anxiety and depression. I live in a community and work and provide supports in my community for students of color that have disabilities and mental illnesses, and just often come across the disproportionate access to resources and just the opportunity to just live a higher quality of life. So all of these factors put together led me to where I am today, where I'm a pretty big advocate for awareness for mental health and mental illness, and then also erasing the stigma. All right, next slide. So what does this mean exactly, right? So what this means is, over the years, I have had both personal and professional experiences with the professionals. And as a result, I have noticed that the language is awful. I have seen how professionals work with individuals of different cultural and ethnic backgrounds, and I have noticed a difference. Unfortunately, I have noticed that a lot of times when the professionals, medical, educational, whichever discipline it is, are working with a person of color, the language, the attitudes are a lot different, and actually a lot less for those of color. And then I look at the other side of this, right? So being a person who is not just a professional in the field, but also an individual who is also a self-advocate and a parent of children with mental health disorders and disabilities, and then a sibling, but then also being a part of a community of individuals themselves that have a lot of stigmas when it comes to seeking mental health supports. and looking at the history as to why that is. And then realizing that the language that's being used within my community often misinforms others, and it gets to the point where individuals are actually suffering rather than going and getting the resources and supports that they actually deserve and that can be helpful for them. I'm also aware of how language, something as just words, can influence others to not see a person as a human or as an individual that needs help, but rather see them as a threat or a monster, much of what Raquel was just talking about. And then I'm also aware of how that effect can also lead to an individual facing some pretty significant legal consequences. And it's all, when you look at it, it goes back to the type of language that was being used. Next slide. So I spend a lot of time on social media, and this picture is one that was going around and still pops up from time to time. But I included this picture because it, to me, is a really good representation of where the problem lies when it comes to the stigma in the Black community related to mental health. So you have the medical community, when you go to them and ask them, why is it that the Black community is not getting access to the different mental health resources that are out there? They point the finger to the Black community. And then when you go to the Black community and ask, they point the finger back to the medical community. And as a result, it's actually some things that need to be taken into consideration and changed on both sides. Next slide. So I dug, and wanted to get more information as to why is it that the Black community has this hesitation to seek supports and get connected into the mental health communities and the resources. And from my research, I found that in the beginning of time, when the different medical procedures, including those related to psychiatry and mental well-being, when those were being developed, often Black people were being used for experimentation purposes. They were being used without their permission, and they were subjected to inhumane, very painful experimentation, without not only their permission, but even understanding what the purpose was. So that in itself caused the community to look at the medical field as a field that was painful, a field that was harmful, and a field that they didn't understand. So that, was probably the initial part of that negative connection with medicine. Then additionally, these medical practices that were being developed, while they were being developed in efforts of addressing different medical and psychiatric challenges that were going on at the time, that was one purpose. But then these experiments were also being done with the intention to prove that the Black race was inferior. So the practices were not being developed in a way that was taking into consideration the Black experience, the Black development of the body, rather than being developed to help the Black community. Again, it was trying to prove that the Black community was less and not worthy. So that's a second reason why the Black community resists or doesn't acknowledge, seeking these medical practices. And then looking to today and even back in time, when medical resources were shared in the Black and Brown communities, they were often shared and still are at a lower quality. The equipment is not as good. It's usually older equipment that was passed down. Um, we see the newer practices not being available. So, when a person did go to a medical resource for help, again, it often resulted in a negative experience. Um, in the 60s and 70s and 80s, when there was a push to close the institutions, we started seeing more prisons open up. And as a result, mental illness was being used as an excuse for incarceration. So at first, it was an excuse for institutionalization, and then later on, it led to an excuse for incarceration. So again, if you're a part of this community that is being disproportionately incarcerated, you don't want to exhibit or report or lead on that you have any kind of mental health challenges out of fear of being incarcerated wrongly. Um, and then, the ones that did actually receive that diagnosis um, in the Black community were often those who engaged in some pretty um, challenging behavior. So, nobody wanted to be associated with that level of behavior. So again, discussions about different challenges with depression or anxiety was kind of kept secret out of fear of being categorized as somebody who was engaging in really, really severe behaviors. Next slide. So in the Black community, when we're talking about stigma for mental health, what does that look like? So first, we have the actual stigma, right? If somebody mentions mental health, immediately words like crazy or being weak pop up in the community. And those are negative phrases that nobody really wants to be associated with. There's often denial when you try to open up. This is something that I personally experienced, when trying to open up about noticing changes in my motivation, changes in the amount of anxiety I was experiencing, and, just bringing it up to family or friends for just some kind of guidance and to share what's going on. And you're immediately met with, there's nothing wrong with you. You're a Black woman. Um, we're strong. It's nothing that we can't handle. We're not like others. And, you kind of have it blown off instead of, I hear what you're saying. Maybe you should think about going to, speak with a professional or something. It's it's a denial, but it's pushed off. And rather than taking what you're experiencing into consideration, you're kind of just pushed to continue to be strong. Um, we often have shame associated with it, right? So again, in the Black community, especially for Black women, it's always taking on this persona of being strong and, nothing can stop you. But then when you start to realize that you're not feeling the same way, you're feeling less motivated, you're feeling, like you just can't do it, immediately you start to feel embarrassed about that. Something's wrong with me. I'm not strong enough. I'm not being who I'm supposed to be. Then we have the cultural mistrust, again, because of some of those historical pieces that I just shared on the previous side. Those are passed down as kind of like a word of caution. So you hear things like, I feel like I need to maybe go talk to someone about my level of anxiety or depression. You don't want to do that because they're going to lock you up. They're going to want to put you in the hospital. You don't want to do that. So from hearing those stories, that will cause us to kind of avoid seeking help. And then in the Black community, there's a very strong religious and spiritual belief. So a lot of times the call for help turns into, well, God doesn't give you what you can't handle. You just need to pray harder. Don't let the devil get you. You're not believing in the Lord enough. Go to church. You need to get back into your Bible. So that will send you down that path rather than seeking, the psychiatric supports and helps that you need. And then, like Seth mentioned in his section earlier, for the Black men in the community, it's a sign of weakness. So it's, you need to toughen up. You're a Black man, and, you're not supposed to have feelings almost. So all of these things that happen in the Black community, which, as has been a result of decades of, you know, abuse and traumatic experiences, it's left us at this point. So this is the main reason why it's challenging as a Black person to get out there and seek the right supports that you need. Next slide. So now we look on the other side with the medical field, and what are the different challenges and barriers there? So again, we look back in history and we see that these different psychiatric procedures, assessments, even the definitions for the different diagnoses, none of that was developed with the Black person in mind. So we have a field that's actually using interventions and strategies based on research that wasn't intended for this, specific group. So that's a barrier and a challenge. Then we also have each person's personal bias, right? That can often be based on stereotypes. And like Raquel mentioned earlier, the different type of language that's used to describe groups. So this leads to when a person is having a mental health challenge, and often a good strategy or intervention is to prescribe them something. We're not seeing that as much in the Black and brown communities because of different biases and stereotypes, like they're drug seekers, or how much stress can you have? They're living off the system, or they're just lazy. They're not trying hard enough, right? So that leads to different treatment in the professional community towards Black individuals with mental illness. When we look at the leadership, and I myself, I try to be involved in as many boards and committees and councils as I can related to mental illness and disabilities, so that I can try to share as much as I can, because I'm just one person with my own personal experiences, but just to be a voice at the table to share the different challenges that the Black community are experiencing, so that it can be taken into consideration. But when we stop and we look at the different leadership in medical research, we're not seeing Black people as represented there. So that's an issue, because that leads to newer strategies and interventions being developed just on what is perceived to be the truth in the Black communities, rather than having the Black community at the table to share their specific needs and experiences. Then we have a lack of resources and providers in the Black community because of the frustration. In the Black communities, we have a lot of individuals that receive the government insurance like Medicaid, and the reimbursement is lower. So we are unfortunately victims of providers being frustrated and giving out lesser quality of care because they're not being reimbursed at the rate that they are with other benefit programs. So, it becomes almost like a conveyor belt in the warehouse where, we're just pushed through as fast as we can with the least amount of connection, because they're trying to make up the difference in the compensation. So rather than spending a half hour to really listen to our challenges and what's going on and getting our history, I'm going to just see you for 15 minutes. So then at least I can see two of you in a half hour and get 3/4 of what I would from one person that, the other insurance company would compensate me higher. So that leads to a lesser quality of care. And then another reason, a lot of the programs and organizations have these different cultural competency trainings, but the information that's included in these trainings and stuff are still often including harmful and false information. We're still hearing things like certain cultures have a higher pain tolerance, or certain cultures are more non-compliant with treatment and follow-up. And, as you go through those trainings and you kind of hold on to those thoughts, and then you carry that into your practice, and it makes a difference in the quality of care that you're providing. Which then leads to the mistrust from the community. And it's just this vicious revolving circle that continues. Next slide. So, I do a lot of presentations all over the country on topics like this. And I always, like to share the details and the specifics and the research. But then I try to end my talks on some key points on how to make a difference. So for this next section is, how do we make the change? And again, I started this with saying, like, this is not a one area needs to change, right? We know that we have like the medical group, and then we have the actual Black community that needs to make some changes for us to actually see some improvements. For members of the Black community, some suggestions are for Black medical professionals to provide and share education resources with the community. So again, like Raquel mentioned earlier, looking at the different grassroots organizations in the community, the churches, the schools, any other community events, and showing up and providing some information in those places to help individuals in the Black community understand that mental health is a part of their health, and that they are worth the time and efforts of seeking the resources and support so that they can feel better, and therefore enjoy their life, that they deserve to enjoy their life. Share different success stories. I think that would be helpful, because we know we have tons and tons of those stories that we use as examples of why the system is bad, but there are a lot of stories out there that show that the system can work for us. So sharing those stories as much as possible. Having open, honest discussions about the concerns, and then supporting each other with finding support, and even attending appointments, just making that call, or getting to that appointment can be really scary the first time. So trying to help out, even if you can't go in person, just letting them know, hey, I'm gonna shoot you a text, what time is your appointment, I'm gonna check on you after your appointment to see how it goes. And something as simple as that can really make a difference. Openly sharing your own personal experiences. I try to share my experiences as much as possible. It's scary. It's not something that you necessarily want to experience, but it happens, and it's okay. And there is help out there. And it's really important to seek help, and seek help in a way that works for you, right? It's not one size fits all. And then consider joining the field. I have been saying this so much. We hear a lot about the lack of professionals in nursing and stuff like that. But also in the mental health field, we need more behavior therapists. We need more social workers and psychiatrists, psychologists, all of that, even peer mentors. So please consider joining the field, not only because we have lots of openings and we need help, but it really does make a difference when you walk into a room and you're feeling vulnerable and you're sharing your experiences and the person looks like you, right? So that's something that I really, really highly recommend. Next slide. All right. So now in the medical field, in the mental health community, what can be done? So the first thing I recommend, and I bring this up in different board meetings and council meetings and stuff, is to take time to reflect on your belief and practices and be honest with yourself and identify the areas that are in need of change. But don't just stop there. Actually change, right? Take time to reach out to Black organizations so that you can collaborate with them and share your info, but then also hear from them, what are some of the challenges and issues that they're noticing and hearing from members of their organizations. Speak up when you look around and realize that you don't see any Black people in the leadership roles or in the leadership, in the room. Or even, when looking around at different resources, pamphlets and videos and, talks and discussions, is that panel diverse, right? Are you seeing representation that doesn't just look like you or, everybody looks the same? Take time to speak with your Black clients so that you learn more about their specific needs. But when you do that, don't just do that and then feel like one Black person represents all of us. But taking the time to get to know your clients and getting a better understanding of the trauma that we still carry on from hundreds of years of traumatic experiences. Taking time to educate yourself. These are two books that I really, really recommend. The Madness, Race, and Insanity in a Jim Crow Asylum by Antonio Hilton is a phenomenal book on the history of mental illness. And then Medical Apartheid by Harriet Washington goes more into the history of the medical experimentation and research practices that happened over the years. Next slide. And then lastly, work with your team to create protocols that need to be followed when working with clients to increase all clients receiving the same quality of care. So creating some kind of checks or balance in your practice to kind of check yourself and, point out if one group or demographic is receiving different treatment than the others. And then promote professional development to learn about supporting diverse groups that are led by that group, right? So professional development is great, but if it's a professional development course or activity about a specific group and it's being led and presented by individuals that do not belong in that group, then I wouldn't recommend it. And then also, once you make these changes and stuff, have some surveys to provide to your clients so that you can get feedback and make adjustments accordingly. And I think that was the last slide for me. Next slide. Yes. So thank you all so much for taking the time to listen to this section of the webinar. And now I am going to pass it on to Muriel Jones-Banks. Thank you.
Thank you, Dr. Z. That was an amazing and powerful presentation, and I appreciate it very much. Good afternoon, everyone. I'm Muriel Jones-Banks, and first and foremost, I am a parent. That's my first title, my first job. And then my second job is I serve as the Executive Director of Federation of Families of Central Florida. Federation of Families of Central Florida is an affiliate of the National Federation of Families. I'm sorry, something popped up on my screen. I can't see the screen. Let me just look at it. Okay, first of all, I want to thank also the Substance Abuse and Mental Health Services Administration, the National Federation of Families, and National Disability Rights Network. To quickly share a little bit about why I am presenting about acceptance, moving away from awareness to acceptance, and from acceptance into advocacy and into action. I have a 41-year-old daughter, and I have a 32, soon to be 33-year-old son who has prepared me for this mental health journey. My son has a diagnosis of schizophrenia, autism, substance use, and a dissociated personality. So I pretty much have my hands full advocating for him, which is kind of difficult because he's an adult now. But that being said, that's why it's important to me to talk about moving from awareness to acceptance. Amy, you can change the slide. I'm still having something blocking the slide, so let's see. Okay, so I'm going to move forward, and we're going to talk about acceptance, advocacy, and action. And as you can see, there's a button right there. I had this button made last year for the national conference in Chicago. I wanted it to be bold, and it's bold. It's pretty big. You can't miss it. And it is actually there to just initiate a conversation. So this year, and actually the beginning of May 1st, Mental Health Month, my staff and I, we're wearing these buttons. As you see, I have my nails painted a very vibrant green, so it sparks conversation. And the conversation has been with the Gen Z, these very young folks that I think are great influencers that were very much interested what all of this meant. I was talking to young folks in Publix, in the supermarket, in restaurants, at the cleaners, anyone who stopped me to say, what's this all about? What is this all about? So it's very important that we change the language to acceptance. So the other thing that I was very excited about, we had last week a community partner who was interested in knowing more about what we do, and they wanted to share what they were doing also in the community. What was interesting, they really didn't know a lot about mental health. So as my staff and I were sharing our stories, just little snippets of our journey with our loved ones, they just could not believe that we were doing this and still advocating for our loved ones. But what I found very, very interesting, they knew everything about autism. Everything about autism. So right away, I knew that, okay, they get it. That means society, the community has embraced autism. Why? Because the Autism Society did an amazing job in moving from awareness to acceptance. And with that being said, the society, the community has embraced it. So they're receiving it, they're receptive to it. So we, who is on this mental health journey, have to do the same thing. We all have to be speaking the same language and wanting the same thing. And then the one thing we need to do is to be a destructive force to eliminate, to stop, as Seth was saying, stigma. I mean, we keep talking about mental health awareness. We keep talking about let's reduce the stigma, and we have not achieved anything. So we are going to have to be intentional about getting it out there and talking about acceptance and what it means. The other thing I wanted to share with you, and I don't know if it could be put in the chat, but National has a YouTube video that I think is absolutely amazing. And what it's about what youth and what families, parents, caregivers, what acceptance means to them. So I don't know, again, if you could put that in the chat and people can go check it out, but it's really so good. There's one parent I have to share that she said, I want acceptance to look like this. For my daughter to be able to say she's going to see a therapist, just like it's easy for her to say she's going to the doctor, but that could be accepted. And I thought about that, and she's right. No one has a problem saying, I'm going to the doctor, I'm going to the dentist, I'm going to the OBGYN. You know, I'm going to get a colonoscopy. No one has a problem saying that. But if you say, I'm going to see my therapist, right away, what's wrong with you? What's happening? That's a stigma that we need to stamp out. We should be able to say, and I know we have some therapists out there, and I know you agree with me wholeheartedly. They're just as important as the physical professionals, the doctors. Even you're dealing with the mind and you're dealing with emotions, and that's important. So saying that you're going to a therapist or getting therapy should not be a bad thing or a shameful thing. Amy, you can move to the next slide. Thank you. Okay, so what I wanted to break down is what awareness is and what acceptance is. So let's look at awareness first. It's the quality or state of being aware, knowledge and understanding that something's happening and it exists. This is the Merriam-Webster dictionary. So if you look at it, it's the state of just being aware. You know what's happening. But if you look at what awareness, acceptance is, it's the act of accepting something or someone, the fact of being accepted, and acceptance of responsibility. Now, I will share really quickly an experience I had. That's why I can really relate to it. 2 years ago, I was turning 65. I was aware that I was turning 65, excited about turning 65, but I did not accept it until I started receiving all that stuff about Medicare. And I had to make a decision. I had to pick plan A, B, C, D, E, and I had to do it by a certain deadline. And right there, I said, oh my goodness, I'm a senior citizen. That was acceptance. And that meant I had a responsibility of moving forward and doing something for myself, advocating for myself so that I have the proper health insurance. So transitioning from mental health awareness to mental health acceptance, it's a shift. And it's towards acknowledging, you're embracing, you're understanding the realities of your loved one's mental health journey. Next slide, Amy. So why acceptance instead of awareness? Well, first of all, we have to eliminate the stigma. We have to stop stigma. We have to get rid of it. So that means breaking down, acceptance breaks down the stereotypes and encourages open conversations. It may be uncomfortable conversations, but they're conversations that need to be had. And it's about mental health. Then encourage support-seeking behavior. When acceptance is promoted, individuals feel more comfortable seeking support. There's no shame. And then to improve overall well-being, acceptance leads to a healthier, more supportive community, benefiting everyone's mental health. So this is why you want to move from awareness. Really, you're not doing anything. And you want to shift into acceptance, where you now have knowledge, you know you have a responsibility, you know you have to move forward. And what does that look like? Next slide, Amy. Research, and I wanted to share this, I think this was very important, has shown that acceptance is also a process of identity development that involves moving past stigma. That's Midzak and Rusnova, 2016. And why should you accept mental health problem if you feel society might shun you for having one? Stigma needs to be disputed to allow for a new sense of self emerge. Acceptance demands we advocate and act to change attitudes, behaviors, and systems. And acceptance is a crucial step on the path to social justice. National Federation of Families, 2024. Next slide, please. Okay, now we're going to talk about advocacy. I don't want to spend time on this PowerPoint talking about acceptance and then not telling you how you actually transition into advocacy, into action, because it's not that easy and it's a process. So to prepare to advocate effectively for your loved one, and I'm speaking of this because I'm a parent, so this is where my experience is, okay? You have to remove your emotions. And I remember the first time I said this to a group of individuals, they were like, how do you do that? How do you remove your emotions when you're advocating for a loved one? Well, let's put your mind on rewind for a second. If you go back and think, when you were first told about your child, explained that your child had a mental health diagnosis, how did that make you feel? How did it make you feel? I can tell you how I felt when they first told me about what my son, or what I had to deal with going forward and how to prepare for it. I was in denial. So when I was listening to Dr. Z, she was hitting on some bullet points. I was like, that's me, that was me, that was me. I was in denial. I was in denial. I was ashamed. I was angry. I was isolated. I isolated myself because I'm like, I must be the only person going through this. This is ridiculous. I doubted myself. I second guessed myself if I would have, could have, should have, that type of thing. What did I do wrong? I felt helpless. But the most of all, I was grieving for a child that was alive. I did not know that until I went to a therapist, because of course it sent me into depression, a deep, dark depression. So I wanted to talk about these emotions. So how do you do that? You have to start by finding someone you trust, that you can vent to, that you can get all these emotions out before you effectively advocate for a child, meaning that you're going to engage with systems of care that are not doing their job, okay? So you have to link yourself with a support group, a family support, preferably someone with lived experience, because then you're with someone who's walking that walk with you. Either they've been there and you're here and they're there, they can get you up where you need to be. But it's a process. It's not easy. I'm the first one to tell you, it is not easy. Give yourself a little grace, little by little. It'll get better, where you will walk into a meeting and you will leave your emotions at the door, because you will become that strong advocate for that loved one of yours, that you're only going to come to the table with the facts, not how you feel, not the emotion, with the facts. Because when you have facts, you're going to hold people accountable. So what other relationships can you build? Where? Definitely build a relationship with your school district. And I'm talking about school administrators. Start from the top. You can start from the top. This is who I am. This is my child. We're going to work together to ensure appropriate services and supports are in place for my child. Get in touch with your faith-based organizations, your churches. Get in touch with your councilmen, your commissioners, legislators. Let people know who you are. Little by little, your name, they will know who you are and what you do. And you hold people accountable, stating the facts. By stating the facts. If you're in an IEP meeting and you know that your child is entitled to a certain support or services, bring that. Whether it's a statute or whatever it is, because the IEP, is a legal document. So that's part of advocacy as well. And also, while you're in these meetings, and I'm sure I'm talking to some parents out there right now, some family members, caregivers, grandmothers, whoever you are, have you sat in these meetings and they refer to you as mom, as dad? Grandma, what do you think? Nip that in the bud right away. And you can do it in such a nice way. I had to do that. Matter of fact, I had to do it on a Zoom last year. My son is receiving his services in New Jersey. I'm originally from Jersey, but I'm here in Florida. And this particular support coordinator called me mom. I gave it one time. Second time she did it, because meanwhile, I'm listening to her call everyone else by their first name. You know, the behaviorist, you know, everyone, she's calling by the first name. So she says to me, Mom, what do you think? And I said, and I'm thinking, Muriel Jones-Banks is all over the paperwork, first of all. Second of all, Muriel Jones-Banks is on my name on the what was it? It wasn't Zoom, it's that other platform. And I said to her, oh, do you have a problem? And I said, saying my name. I said, because I know some people say Muriel, some people say Marion. I said Mariel, but it's Muriel. And I said, if you find that difficult, you can call me Mrs. Banks. The look on everyone else's face was like, oh my God, I can't believe she just said that. And then I had someone send me a private chat and said, kudos to you, Muriel. So you are important. You are that professional. And you have to demand that respect in a nice way. Stop having them call you mom. You have a name and they need to use it and respect it. And the other thing holding people accountable, document, document, document. That is my big thing. Document, document, document. If you're in a meeting, if you're able to take notes, take notes. Although the other side should be taking notes, they should be providing you with a draft. Check your notes against their notes. If something is missing, you email them, copy everyone on it, and say, oh, I just need you to edit this or revise this, and please resubmit email. If you're a person that likes doing phone calls, which I'm not a big fan of that because people can say anything or say they didn't say it, then you need to follow up with an email and say, I'm just following up, or thank you for your time for the phone call. I just want to memorialize our conversation and da, 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 da. That's it. You're documenting it and you're holding people accountable. Because if you don't do that, no, it's a vicious circle. You're just losing. You're just digging yourself into a deeper hole. So you are your loved one's best advocate. You can move forward, Amy. So what have we learned? We're going to put our emotions rather, in check before we go into action. So you want to move forward from being silent. It's very easy for the systems of care, whether it's school, behavioral health, whether it's your child going through DJJ, very easily to be intimidated by the process and the people around you. But you have to be strong and know that you are your child's best advocate. When you are making a request, be very specific. Be clear on what you're asking for. Don't leave it up to others to say, well, she was very generic, so we're just going to pick this. No, you need to be very clear on what you're asking. And never, ever stifle your passion. Do not let anyone water down your story. Your story has value. You have value. You bring expertise to the table. Always remember that you are the professional of your child. You may not know all the resources, but you know your child and what's best for him or her. And then also, like I said, you got to play nice in the sandbox, because you're going to be with people that are opposing you, that are judging you. I've had people judge me. You're a bad mother. You need parenting classes. Please, really? Parenting classes? I have a child with special needs. They don't make a manual for that, and they do not make a manual for parents, what to do as a parent. We all know it's all trial and error. Let's keep it real. It's all trial and error. You do the best with what you have at the time. The next thing to do, I cannot emphasize enough, do your research. And if you have problems doing your research, reach out to someone that can help. Reach out to that support group. Reach out to that trusted person. Reach out to your family support organization. Reach out to hey, look, National has a technical assistance. All right, reach out and get the help that you need so that you have that toolbox of advocacy that has built you up. You educating yourself through webinars like this, conferences, workshops, anything that's free, you should take advantage of. That's all I'm saying. Now, the one thing before I end, which is very important to me, I want you to think about this. What is your acceptance? You take the time, because we're talking about moving from awareness to acceptance, to advocacy, and to action. What is your acceptance? I can share with you what mine is. My acceptance is I am the expert when it comes to mine. I may not have a whole bunch of alphabets after mine, but I have walked this walk and this journey. I've lived this and continue to live it. Anyone who have heard me speak before, I always say it's the same book, it's a different chapter. My son is 32, so we're in chapter 32, okay, of the book. This is a journey. If this was a Netflix, I'd probably be in season 32. All I'm saying is know what your acceptance is. What is your acceptance? And check out that video. Check out that video and you'll get an idea. But please, in order for this mental health community, all of us that's going through this, and all of those professionals who are truly helping families, let's all speak the same language. Let's stay away from awareness, step into acceptance as a warrior, because we are warriors. Stop worrying, be a warrior, and be the change. I believe the next slide I should be done. That's who I am, Muriel Jones Bank, parent. Thank you so much. And there should be resources in the next slide. Thank you.
Oh my goodness, what a day this has been. I hope everyone has enjoyed this. I know we would love to do this for another hour and a half, but unfortunately I must be very respectful of your time. I'm sorry we can't get to questions, but if there are questions in the chat, we will do our best to get answers to you. I just want to take a minute and thank all of our presenters. Thank you for centering us on the need for person-centered language and how that leads toward equity across all communities. And with that, Kelly, I will turn this back to you.
Thank you, Linda. And I just piggyback what you said. Thank you so much to our 4 presenters today for sharing such powerful nuggets. I think everything that was said today hit home to most of all of us. I'd like to give SAMHSA a special shout out for sponsoring today's presentation. And again, thank you to the participants for joining us. As you exit today's presentation, please take a moment to fill out the survey that you'll see in your browser. And if you have any additional questions for our presenters, I believe their email addresses will be in the PowerPoint presentation that will be shared with you. Thank you again for joining us and enjoy the rest of your afternoon. Take care, everyone.